So a very, very warm welcome to all of you. And thank you for joining this session. It's a real pleasure to have all of you in this session. Thank you to our speakers to have sent their proposals, and it's a real honor to be selected to present the work that you have been doing. As we all know that since 2020, we have all seen very difficult times. The struggle has been for everyone, but more so for the most marginalized and vulnerable sections, whether it is refugees, whether it is women, whether it is people who are daily wagers and laborers and do not have a sustainable source of income. We know that COVID has impacted a lot of communities disproportionately and has changed their lives drastically. And the hope that comes is from the work that civil society puts in, that multilateral agencies have put in, and that people who believe in equality and in the principles, in the social values, and they are the ones who keep our hopes alive, and of course, the resilience of the community. So with these words, I have great pleasure in inviting our very, very eminent speakers who have come up with, very inspiring ways of connecting with the community and doing whatever we can in these difficult times. So we are going to start. We have 4 speakers with us, and I'm going to start with Umme Halima. She's a leading social and behavior change communications expert, and she works in the Khulna region with UNICEF. She provides technical support to the government and CSO partners and academia, religious institutions, and other social networks for SBCC planning, research, and program implementation. She has a background in behavioral communication strategies for global epidemics and social and behavior change programs. Currently, as I said, she's involved with UNICEF. And besides UNICEF, she also works with other multilateral agencies like UNDP and Save the Children. So over to you, Ulema, over to you and Umme, and we really look forward to hearing what you have for all of us.
A very good afternoon, Archana and everyone. In this session, it's really delighted to join with you and share our experience. So I'll be only 10 minutes, so I'll try to keep on time my presentation. So on my presentation, can we go with the first slides, or should I open my window here, or okay? On my presentation, I'll be focusing on, first slide, please. Okay, on my presentation, I'll be focusing on sharing the experience which has taken by the government initiatives with support of UNICEF. So we call it as a special risk communication and community engagement efforts to combat COVID-19 in border adjacent communities in southern part of Bangladesh. So I've been sharing.
Maybe we are losing
experience from one
voice.
district and with engagement of multi-stakeholders. Can you hear me? No? Am I audible?
Yeah, you're audible, but it comes and goes in waves. But please carry on.
Okay. So what I was just saying is that I'll be sharing brief about the experience that we have in preventing, the spread of coronavirus in one district. So on the little bit of the background, that during the Eid festival, which is during the April 2021, from the DHIS2 data, government data, it shows that in between of the March and the June, the confirmed cases of the COVID has really upward, and it goes up to the more than 36% of the population identified as confirmed cases of COVID. So when we are talking with the local government as well as the health department officials, they come up with the several reasons for this upward trend of the COVID. And it's saying is that, during the festival time, there's huge mobilization of the population. They're coming from one district to another district. Also in different border areas, the transport and the trades that's really increased during the festival time, and also the overcrowded business and the transportations in local market areas. Several land ports were also open, but most importantly, we have seen that the people in those areas were really reluctant in wearing masks and practicing other COVID protective behaviors. So second slide, please. Okay, so when we have seen this situation, so we very quickly, with the local government institutions, we have done a very quick, rapid behavioral assessment to understand the people's behaviors in terms of the mask wearing practices as well as the social distancing practices in those hotspot areas where we found that the COVID confirmed cases really was upward. So as I've been going through very quickly, the observation that came out through the assessment is that you can see, especially in the tea stall areas, there was only 24% of the population used to wear the mask, and which was really high in public transportation, which is intercity transportation. People used to wear masks in 79%, but the percentage varies in different areas like bus and rail stations. 59% population used to wear mask, and the border areas, which is 72%, and budget areas, hard budget, 62%. So when we are seeing the data from the social distancing, we have seen that only 16% population used to wear the mask in those areas. So when we are talking, when we are seeing the findings from the KII, which was done with the health department and the religious leaders and other stakeholders, that came out like, the people were not used to wearing masks because they are not habituated wearing masks for a long time. Now, so, sometimes they are not really think that COVID is, if even anyone use the mask, they will not maybe support him to prevent the COVID. So those came. We also wanted to know from these studies that what are the communities' preferred channels in terms to promote protective behavioral messages in those areas. They also suggested that the local socially influential leaders, the street miking, dramas, leaflets, and posters could be the, the useful channels, communication channels to promote the protective behaviors among the communities in hotspot areas. Next slide, please. Next slide. Okay. So we worked through 4 strategies with these special initiatives. So the first strategy we have taken, the evidence generation, which is, which I've just shared, the behavioral assessment and sharing findings with all relevant stakeholders so that everyone could come up together and take the initiatives and promote the protective behaviors from their end. The second strategies, we have taken social mobilization and multi-stakeholders engagement, which supported continuous coordination and collaboration with local partners and stakeholders in these initiatives. And the third strategies was community engagement, consultation, and feedback to promote protective behaviors, to readjust localized community engagement and messaging. And of course, community feedbacks is very important in these RCCE initiatives so that they feel and own the initiatives and they can adopt the behaviors. And the fourth one was tailor-made messaging and channels, which which is very crucial in terms to have the local context in the messaging. Also, the materials that we have gone through with during this pandemic time. You can see on the right side of my slides, there is several public service announcements which focus particularly on as well as in border communities. So there was PSA developed for the hotspot local markets and hard bazaars, as well as like the population who were living in the border adjacent communities. A lot of posters and as well as the billboards, which were all locally developed and disseminated COVID protective behaviors. Next slide. Can I go with the next slide, please? Okay. So with this strategy, 4 strategies, when we develop this project, we come up with stakeholder, earlier slide. Earlier slide, please. Okay, thank you. So we come up with the analysis of the stakeholders. As you know, in RCCC initiative, that's very important to understand the influence of the different population to promote the behaviors and to adopt the new behaviors. So we identified as a primary stakeholders like the border adjacent communities, businessmen, customers in local marketplaces, transportation workers, assistants, as well as intercity transportation officials. As a secondary stakeholders, we have identified that Upazila administration, local markets owners, mosque management committees, religious leaders who really have the influence in terms of messaging on protective behaviors, as well as to promote the protective behaviors. And tertiary level, of course, the district administration played very active role. They played the key role. Border guards, health department officials all come up together to work on this. You can see some of the pictures besides that of the engagement of different stakeholders. Can you go with the next slide? Okay, so on the key result, I have not, I'm not sharing the like numbers, how many numbers of population were mobilized, or the imams, religious leaders, or the the intercity transportation or the transportation officials were trained. Later, I've been focusing on how the different stakeholders were mobilized and the reinforced for RCCC messaging. As you can see on the key result, that district and Upazila administration with local government institutions, they played the key role, and border guard, intercity transportation owners, market management committees, mosque management committees have been advocated and reinforce the protective behavioral messages. And of course, especially border guards were mobilized to reinforce mosque using, especially in the hotspot areas, local markets and hot bazars. As I have already mentioned, that bus drivers, helpers, and transportation officials also sensitized and oriented on protective behaviors and interpersonal communication to encourage people to increase the mask wearing in the mass transportation and to maintain physical distancing and hand washing. And the last thing is local market owners and local government institutions also mobilize communities. They often take in the communities' views and have taken their feedbacks as how the messaging could be improved. Even what are the places to, to set up the street miking and where to set up the billboards, etc. So in terms, when we are looking at the data from the DHIS dashboard, which is a government dashboard for the COVID, the confirmed cases to see. So we can see during the July to November, the trend has really decreasing. And we can see that during the October and November, which is started from the September, the COVID confirmed cases even below the 5% in those selected areas. So I just wanted to share is that in these RCCC initiatives, communication and community engagement initiatives, localization is very important. So when we come up and the engagement of multi-stakeholders, if this applies properly, I think the approaches really worked well, and we can see throughout the several months of the initiatives of different stakeholders which engaged in these initiatives that really worked well. So thank you.
I'm sorry, your time is up. Just 30 seconds to wrap up.
Yeah, my presentation has ended. Thank you.
Okay. Thank you so much, Umme. That was really very enlightening. And also it's very similar to what we all are going through, in the sense the trends when it gets, it spreads, and, the multi-stakeholder approach and reinforcement of masks. I think that is a takeaway which all of us have also learned through our own experiences. And thank you so much. And maybe if we had time, we would have asked about the specificities of the border area, but maybe later if we have time. So thank you so much, Umme. And without much ado, I'm going to move on to our next presenter. And we have Arif, who is going to present from Bangladesh again, and he is right now in Cox's Bazar, and he has been working with the Rohingyas. So Arif ul Mamun, head of research, BBC Media Action, he's currently supervising and managing all the research activities that BBC Media Action has undertaken in Bangladesh, including response to the Rohingyas during the COVID pandemic. And also with us is Banna, who has also worked on the presentation together with Arif. And Khandokar Hasanul Banna is working as a humanitarian project manager in BBC Media Action Bangladesh. He's working in Rohingya response. He has been working in the humanitarian sector for the past 7 years, mostly around communication and community engagement, accountability, and research. He's also a trainee board of trustee of CDAC Network, a leading global network of community engagement and accountability. So over to you, Arif and Banna, and we would love to hear about Rohingyas, because where I run my community radio station in Mewat in Haryana, we have a huge settlement of Rohingyas. So there'll be a lot of lessons to be learned from your presentation. Over to you.
Thank you, Archana.
Hello, everyone. Many thanks for joining us today.
Are two of you logged in the same room with the same thing? So I think one of you has to switch it off and use the same one.
Sure, yeah. That's what we're doing. Thank you.
Please.
And thank you to the South Asia Regional SBCC Conversation organizers for inviting us here to talk to you today. I am Khandokar Hasanul Banna from BBC Media Action, joined by my colleague Arif Mamun, who is the head of research for BBC Media Action Bangladesh. In this session, we are going to tell you about our project in the Rohingya response to improve communities' access to information by bringing communication and health expertise together through the COVID-19 pandemic. Since October 2017, the Common Service for Community Engagement and Accountability, led by BBC Media Action, has been working to ensure Rohingya refugees and their surrounding community in Bangladesh have access to information they need, and to highlight their needs and priorities to humanitarian responders. When the COVID-19 pandemic started, movement restrictions in camps impacted on how humanitarian agencies were able to communicate with the Rohingya community at a time when accurate and reliable information was critical to dispel rumors and help people protect themselves and others. The Common Service was able to play a crucial role in three different ways. First, helping humanitarian agencies to understand Rohingya community's perspective and concerns, any rumors circulating in camps, and how best to communicate based on up-to-date research and cultural understanding developed over time. Secondly, by creating and supporting others to create engaging audio-visual contents, which is easy for Rohingya community to understand. And finally, working in partnerships with others to adapt communication strategies and ensure information was reaching people despite the restrictions. An example might be helpful here. BBC Media Action was developing audio content with the World Food Programme to play at food collection points, and developing video training materials for health workers, and a flip chart with World Health Organization for community health workers to disseminate critical information about COVID-19 safety within the camp. Recognizing mosques remain the key source of information for the people, the project created short audio bulletins suitable to be played on loudspeaker and trained imams on the community engagement around COVID-19. A mixed method study was carried out to evaluate this phase of the project, including a representative survey with 2,678 Rohingya and 1,050 host community members, and a qualitative research with humanitarian practitioners and religious leaders. Let's hear about the research more from Arif Mamun.
Thank you, Banna, for the introduction. Now let's see at glimpses of some key findings. Despite movement restrictions and service closures imposed due to the COVID-19 pandemic, access to information remains high within the Rohingya community, with 60% saying they feel informed about COVID-19. Women report more access to information than men. For example, 54% women feel more informed about COVID-19 compared to 46% men. We think face-to-face community-based communication interventions have paid off in the camps. Rohingya women are the group which feel most informed and indeed have the most knowledge about COVID-19, as they benefit from the face-to-face discussions through door-to-door visits from volunteers they trust, as well as at listening groups and women-friendly spaces. As you can see in this slide, majority Rohingya people know about the symptoms of COVID-19. Approximately 72% Rohingya mentioned they know COVID-19 symptoms and mentioned high fever and coughing as symptoms for the coronavirus. When asked, what should someone do if they have symptoms of coronavirus? 72% Rohingya people exposed to common service COVID-19 content mentioned the most important answer: isolate themselves away from others, compared with 49% of unexposed Rohingya people. Advanced statistical analysis found that Rohingya people who had seen or heard common service content about COVID-19 are 1.6 times as likely to have obtained a high knowledge score about COVID-19 than those who had not. When asked how should you wash your hands to prevent the spread of coronavirus, 47% of people who were exposed to the content mentioned 3 or more things to do when hand washing, compared with 31% of unexposed Rohingya people. As you can see from the previous slides, all the knowledge indicators are quite high. Much of the work about COVID-19 carried out by the Common Service during this phase was focused on supporting humanitarian agencies to communicate effectively with Rohingya and host communities in Cox's Bazar. In the Rohingya community, a higher proportion of people who attend listening groups and food distribution points and live close to the mosque feel informed about COVID-19. Living close to a mosque makes the biggest difference. People who live close to a mosque are 3.2 times as likely to have high knowledge about COVID-19 as those who do not. One possible explanation could be, we know that the highest proportion of Rohingya people said they received information through miking, and mosques have increasingly taken a role in sharing information about COVID-19 via loudspeakers. In addition to that, we also found people who are exposed to the common service communication content are 1.6 times as likely to have high knowledge about COVID-19 as those who are not exposed. Findings from this study point to different hypotheses about how information leads to action in Rohingya community, which is laid out in the diagram of this slide. Rohingya people receive information in Rohingya language through loudspeaker announcements from mosque, by attending listening groups and visiting services in camps, or through door-to-door communication where they interact with NGO workers and volunteers. The evidence suggests that common service content or communication materials play an important role. Information they receive through this interaction at these facilities leads to higher knowledge about COVID-19. This leads to the feeling that preventive measures such as mask wearing is important, and this leads to wearing a mask when near to other people. Our research has found that the Common Service has played an important role in supporting the Rohingya community during COVID-19 pandemic through creating and disseminating audio and visual content which is easy for Rohingya people to understand, and the data suggests has contributed to improving their knowledge about COVID-19 through working in partnership with humanitarian agencies to adapt communication strategies and make sure information is reaching people in spite of COVID-19 restrictions being in place, particularly supporting face-to-face initiatives like the flip chart for the community health workers and adapting audio programs to be played through loudspeakers, through helping organizations understand how to communicate effectively with communities through language training, sharing research in what matters, and providing advice to the practitioners based on deep cultural understanding and solid understanding of communities' current perspective and priorities. So, based on the research, we think the Common Service should continue to advocate for, support and equip humanitarian agencies to do face-to-face communication in the Rohingya community, as this has been especially effective at reaching women. Face-to-face interventions targeting older people, understanding more about their particular needs, and taking this into consideration could help that group feel as informed as younger age. A focus on communicating with women in the response has paid off. with Rohingya women feeling particularly well informed. The Common Service should work with partners to ensure men are also engaged in communication initiatives. The ability to provide feedback has decreased since the beginning of the pandemic, with highest barriers for women and people with disabilities. Equipping door-to-door volunteers with the knowledge and systems of how to collect feedback and refer people to appropriate services could help redress this balance. This should include efforts to overcome existing cultural, contextual, or other barriers which prevent certain groups, particularly women, from providing feedback or making complaints. The Common Service can play a role in helping agencies to do this. This study found that what matters is valued in the response for providing an objective view of communities, priorities, and perspective. The collective feedback service is only effective if partners continue to share data with Common Service. The Common Service should continue to support partners in setting up and maintaining feedback mechanisms and ensuring communities can continue to provide feedback during periods of restricted movement. The study found that adaptability is the key. The Common Service should continue to assess the best way to reach Rohingya and host communities with information as the situation develops, and continue to adapt its approach and its communication materials, partnering and working closely with humanitarian agencies and sectors to ensure they are reaching as many people as possible. That's all from our side about pitching it right, bringing communication and health expertise together to support Rohingya refugees through the COVID-19 pandemic. Thank you again, SBCC South Asia Regional Conversation Committee, for this opportunity.
Thank you so much. This has been very, very informative, and congratulations for the commendable work being done by all of you. Particularly, you mentioned face-to-face interactions, and it must have taken a lot of courage to go, because, you know, I have visuals of Cox's Bazar, and I know how packed that place is, and to go and do this work face-to-face, risking your own lives and your health, commendable indeed. A couple of very interesting things which you said, that people who were living closer to the mosques were better informed, which is also a very interesting finding. And of course, your actions led to, your information led to immediate actions, whereas we are concerned, it's always information, then it takes time to absorb the information, and then it takes time to act on that information. So it's a three-tier process which normally takes for people to respond. But I think your face-to-face interaction, your commitment, and the work that you have done is amazing. So congratulations once again, and thank you so much for sharing this. I move on to our next speaker. I think that our fourth speaker is not joining, but then that gives us time for a Q&A, and time is just running out. So I'll quickly move to Sushmita. And what Sushmita has done is very interesting, and especially when we are all talking so much about COVID. Sushmita, we are really looking forward to hearing from you. And we only talk about the deaths and the crisis of COVID, whereas we have forgotten about what tuberculosis actually does to the lives of people. And according to an annual report of the National Tuberculosis Elimination Program in India, we reported over 24.4 lakh tuberculosis cases in 2019, and it has only increased a bit in 2020. And what I'm reading, and I read, was that there were over 79,000 deaths due to this bacterial disease. And this has led to the fact that, there has been a huge spike in the cases of TB in our country. And when we've all been so involved with COVID and the pandemic and related lung diseases, we somehow seem to have forgotten about this disease, which takes about 15,000 lives every 3 months. So, we are really looking forward to hearing what you have to say. And let me introduce Sushmita Malaviya. She works as a National Operations Coordinator with REACH, with REACH's Accountability Leadership by Local Communities for Inclusive Enabling Services. It's called, the acronym is ALIES. It's an ALIES project in Delhi. She has a media and communications background, having worked as a journalist, then moved to UNICEF, PATH, John Snow India Private Limited, and Mamta Health Institute for Mother and Child. So with all this very rich experience, Sushmita, over to you, and very much interested in hearing your presentation, listening to it. Can we start?
Good day all. I am Sushmita Malaviya, working as a National Operations Coordinator in the Allies project that is supported by a USAID local organization network grant to REACH. The Resource Group for Education and Advocacy for Community Health, REACH, is an India-based non-governmental organization that supports care and treatment for people with tuberculosis. Since 1999, REACH has also been involved
stop
in
for a minute,
research, advocacy, public education, and
can you pause?
communication. REACH is currently
implementing. You know, we can't see anything. The screen is a blur. Is it only my problem or it's with everyone?
I've got a clear screen, Archana.
You've got a clear screen? Okay, thanks, Priyanka. Sorry then. Yeah, please carry on, Akhil.
The accountability leadership by local communities for inclusive enabling services, allies, project in 4 states of Chhattisgarh, Jharkhand, Orissa, and Tamil Nadu. The goal of the project is to create enabling environments for TB elimination by leveraging community action as an ally to build a culture of accountability through a rights responsibility-based, gender-sensitive approach with an aim to empower even the most marginalized communities to take ownership of TB prevention and care efforts. As we move ahead, it is important for us to understand who TB champions are. For a little background, through the TB Call to Action project, REACH empowered TB champions with successful outcomes. Empowered following from TB survivor to TB champion training, the TB champions had established themselves as credible advocates for pro-health behavior and proved to be a valuable support to the TB program at the district and sub-district levels. We would also like to share here that the profile of a TB champion could be very varied. You could have a TB champion who is a homemaker. You could have a TB champion who is a student. You would also have a variety of learning levels, some semi-literate, some up to their graduation level. This empowered cadre of TB champions faced an unprecedented challenge to continuing their field work as the COVID-19 pandemic brought them to a complete halt. The Allies project leveraged this cadre to continue their engagement with relevant stakeholders, keeping all COVID-19 protocols in place. The TB champions themselves realized that communication and engagement with TB-affected communities were critical, both as part of supporting the TB program and recovering from the devastating impact of the COVID-19 lockdown. Almost step by step, the TB champions learned the importance of technology. They learned the importance of keeping in touch. The Allies team constantly nudged them to start collating the information that they were getting from their geographies. Gradually, TB champions were brought onto the Google or Zoom platforms where they were able to discuss what they were seeing and hearing in their areas. Once they were able to put some sort of reports together, the Allies team facilitated virtual interactions with the state TB officers, where the TB champions presented their findings and sought immediate support from the TB program. This established a system of regular e-meets, not only amongst the TB champions, but with the state level TB survival-led networks to keep the dialogue not only with community going, but with the state TB program as well. It was at this critical juncture that REACH conceptualized a communication skilling for selected TB champions. Given the lockdown situation, the curriculum was developed along with TB champions and was delivered virtually over 20 hours. Most TB champions attending the training through their phones, some for the very first time. Through these various interactive sessions, the training focused on different aspects, including an introduction to communication and how it was connected with the work that TB champions did. The TB champions were introduced to the concepts of using songs, poems, slogans, wall writings, videos, and photographs to accelerate strategic communication both around tuberculosis and COVID-19. Alongside these efforts, REACH also rolled out the Learn to Lead series, which is a series for knowledge building for the TB survivors and champions. In unprecedented times, the communication skilling training followed by the community engagement activities bolstered the confidence of TB champions. Gradually, understanding the new normal, TB champions spoke of their lived experiences and resumed their fieldwork. Their work and the communication products developed have helped allay apprehension and reduce stigma around both TB and COVID-19. Here are glimpses of the easy to understand songs, poems, slogans, wall paintings, videos and photographs with messages on TB and COVID-19 that were developed entirely by TB champions. Thank you so much for your time and your interest in the work that REACH does with TB survivors and TB champions.
Thank you so much.
It is our honor to share with you a few glimpses of the work of our TB champions, as well as a short video that has been developed.
भेदभाव छुआछूत दूर करेंगे, टीबी से जंग लड़ेंगे, सरकार ने लगा ली दम, 2025 तक देश को हम टीबी से मुक्त करेंगे।
आइए बताइए, आपका नाम क्या है?
जी, हमारा नाम मोहम्मद हसन
शेख।
मोहम्मद हसन शेख।
अच्छा, आप पहले दवा कहाँ से खा रहे थे?
दवा इलाहाबाद से किया करते हैं।
इलाहाबाद से किए, तो 2 महीना का दवा आपका ख़त्म हो चुका है ना?
हमारा 2 महीने का दवा खत्म हो गया।
तो आप फिर सीबीनेट का भी जांच करा चुके हैं। अब सीपी का दवा यहाँ से ट्रांसफ़र किया गया है ना आपको इलाहाबाद से। और दवा खाने से पहले आपको कैसा था?
बहुत खांसी था, जुकाम, बहुत खांसी जुकाम तो खत्म ही नहीं होता था।
हाँ।
ये दवा खाने से खांसी जुकाम बिल्कुल खत्म हो चुका है अभी हमारा।
Thank you, Sushmita. That was really, really nice. And I loved the video. It was so simple and so beautifully presented. And as someone has already written here, that champions and warriors are very much required. And we have so many diseases to fight and such major health issues that we need more and more champions and warriors, and especially if students can join in, nothing like it. We were thinking that we don't have our fourth speaker because she was finding it difficult to join. But now we have Parwana Hamdam from Afghanistan. And Parwana, over to you to take us through your presentation and to share your work with us.
Hello, Archana. I hope all is well. So sorry, just I had some problems connecting. So now I'm going to share the screen. Like, Dr. Farid, do you want to share the screen or should I share the screen?
Yeah, we will share it for you. We will share it for you.
Yeah.
Share it.
Parwana, we really, the heart stops after 10 minutes because there's another session and we'll have to really wrap up in about 9 minutes if it's not a problem.
No, it's not a
hearing you.
No, it's not a problem. Like, no worries. We will finish as soon as possible. So first, like Dr. Farid will go first, and then I will join. I will do the rest of them. Dr. Farid, over to you, please.
Yeah, thank you so much. We'll be brief. So me and Parwana, like in Afghanistan country office, as you see, we combine COVID-19 and hygiene as a community engagement intervention for internally displaced population. So as a risk communication and community engagement lead, Parwana, please change this presentation next. We use different methodologies to increase awareness and engage communities. Like we use community engagement interventions, social media, mass media intervention. We use like systematic data collection and call center of the Ministry of Public Health in coordination with WHO Ministry of Public Health. So while implementing our community engagement interventions, we use different methodologies: implementation through government partners, direct implementation through UNICEF social mobilizers in some cases, media services and civil society organization and NGOs. So what we did with our one of the partner mobile mini circus for children, we had 2 objectives for internally displaced population. So all vulnerable families in these communities, they should access to supply to the supplies that they need, like it's bars, like soup bars, like hand washing facilities and other. And the second objective of this intervention was these should know about COVID protective measures, like what measures they should take in order to be protected from COVID-19. So what were our mechanisms of engagement with MFCC? They were using innovative mechanisms or systems, like they use distribution of supplies, mobilization of volunteers, and community engagement. And then they conducted campaigns through circus. Now over to Parwana to take us to the rest of the presentation. Thank you so much.
Thank you so much, Dr. Farid. So if we go to this slide, like in the part of supply distribution, we can say that TP taps was totally a new innovation in Afghanistan, so which was used to them by them, and they just recycled the bottles, plastic bottles, and make from them TP taps and distributed to the IDP camps. And the other was about public hand washing facilities, because in the camps they base on the need of the communities and the people in the camp. They put some hand washing facilities, and the other was about distribution of buckets and barrels, and at the same time they distribute some soaps. Can we move to the previous slide, please? And may I request that those who are not just talking mute your mics, please, because it's disturbing. Yes, thank you. And at the same time they distribute soap bars, and at the same time as well as liquid soaps. Can we move to another slide, please? So about the training and community engagement, so some basic trainings was conducted to the peoples from within the communities. They just identify some volunteers with the knowledge, and they train them on how to distribute the TP taps, how to use the TP taps, and as well as hand washing components. And those volunteers from the same communities was trained, and then they went to the communities and they mobilized the communities and they engage people, and they put and they raise awareness of the people on COVID-19 and psychosocial supports. So if we come to the campaigns, so there was two major campaigns. One was the bicycle campaign, in which they used bicycles and went to each place in streets and raised the knowledge and awareness of the people. And the other was about Corona campaigns. As you can see in the pictures, like they put the formats of like the clothes costume of the COVID-19 and Corona, and went to the streets and mobilized people and raised the people awareness. Can we please move to another slide? So what's innovative in this intervention? So first of all, TP tap was something new in Afghanistan, and they used TP taps like you can see in the picture. The other was like, it was more like fun, and instead of just putting messages and delivering the messages. So they used fun methods, like they made circus for the children to raise their knowledge and awareness. And the other was about psychosocial support, and as well as using bicycles by volunteer, like using bicycles, putting the Corona costumes and running to the streets, walking around the streets and raise the knowledge and awareness of the people. So if we come to the final results, so in Kabul, they reach around 25,000 of people, which includes 3,616 families and 19 camps and 25 communities. And in Herat provinces, they reach around 4,000 people, which includes 650 families. So the total reach of this intervention was around 27,000, which includes 4,259 families in 22 camps and 28 communities. Can we please move to another slide? So how we did the monitoring, like the weekly monitoring was done by the NGO MMCC, and at the same time we also did our monitoring, joint monitoring by MMC and UNICEF, and the photo and videos, or you can find the photo and videos through the below links. So can we move to another slide? So what was the lesson learned from this intervention? Like, first of all, like it's really effective if we mix both supply part and hard component and soft components when we want to do something related to WASH and COVID-19. And another lesson learned was that we did this intervention because it was emergency. So it is really necessary to conduct some need assessment prior conducting any interventions, because like the need of the community really matters. And the other was like the TP tap, which was distributed, like it needs more analysis, the size, the way it was designed, and the material which was used to make the TP tap. So more analysis was needed to design the TP taps based on the need of the communities. And the other like lesson learned was that we need to engage more female social mobilizers to reach more families, especially females and women in the camps. And another lesson learned was that we need to engage more community members in our stage of this intervention, like even from the design part. But in this intervention, the community was engaged when we designed the project, when the project was already designed. So this was the all lesson learned from this intervention. Can we please move to another slide? So I think that's done from our side. I think we took more than 10 minutes. So if there is any question, Dr. Farid, and I'm here to answer. Thank you.
Thank you so much for your presentation. And it didn't seem as if you took more than 10 minutes because it was indeed very, very well presented. Unfortunately, we have no time for questions. I really need to thank everyone. And I'm very happy that Parwana, you and Farid ji could join because we would have missed out on something. We've touched upon almost all the vulnerable communities and you brought in the gender aspect, as did others too. So thank you so much for this very, very enriching session. I'm going back with more information, knowledge, and inspiration to make a difference, and maybe also join in as another champion. I'm just hearing from the SBCC team. One side, I'm getting a message that I should wrap up. Other side, I'm told that we still have 3-4 minutes. So let's take advantage of the 3 or 4 minutes. I don't know, Priyanka, do we have time or we don't have time?
Sorry, I will leave that to the SBCC summit.
Yeah, I think we don't have time for questions, so I think we should wrap up now.
We don't have any time for questions, unfortunately.
It's 11:44 though. So I'm wondering whether we can spend 5 minutes because it's only 11:44 and the next session starts at 11:55.
I think we'll have to begin the next session.
5 minutes. Yeah. But I think we'll find a midway. We'll take 2 questions if anyone has any, especially for our team from Afghanistan. So, if anybody has any questions, please quickly ask. It was a beautiful presentation done so quick. Each presentation was so lovely. But my question is that the challenges must have been huge, Parwana and Farid, the challenges must have been huge to reach them, to work with them, and to engage with the IDPs, and especially the resources. How did you manage the resources in these very tough times?
Thank you so much. We partner with one of the NGOs like Mobile Mini Circus, they have good community networks, they have been working with these IDP camps for more than 20 years, and they have volunteers within the camp. So they're engaging and their volunteers are going on daily basis, and even their connection with the communities, in each communities, they're distributing bicycles. So while the community members are coming to their training center, they're using bicycles during coronavirus. One of the innovation was to use bicycles in order to not be affected by COVID-19. So their engagement with the communities was quite impressive. And they were once we did the analysis, only 2 people in these camps were affected by coronavirus. We did our observation, that was not much systematic, but we went to several camps. And we got that only 1 or 2 people in these communities, despite their challenges that you saw the pictures in which situation they were living. You see their mud houses without water in other areas. So only they were able to tell us what the symptoms are and how to prevent themselves and their families. So the impact of the intervention was good, and they used innovative approaches. Some of the challenges that Parwana mentioned, in some camps, they didn't have water. They had water, but they were bringing those from very far areas. So what we recommended to our program people to connect supply side more aggressively. If there is no water, our wash section should build water pump and support us in that area. However, we did provide with supplies, hand washing facilities and other, but these have to be, these dots should be connected in the future. This is why we brought it under our lesson learned.
Thank you so much. We are really running out of time. Thank you, Sushmita, Farid, Parwana, Arif, Banna, and Umme. Thank you so much for this lovely, lovely session. Honestly, I feel more enriched.